We move on to the second presentation, that's on management of hypertension in obese. Is it different? May I invite Dr. Harendra Kumar, who is a Joint Director at the Indira Gandhi Institute of Cardiology from Patna, Bihar. And Dr. Kumar will have 11 minutes for his presentation.
Good afternoon, everybody, respected chairpersons. Obesity is an important risk factor for hypertension. Linear correlation has been found between body weight and blood pressure. Obesity may be generalized or abdominal. You all know, if the overweight is by definition, BMI is less than 30 and obesity is BMI is more than 30. You all know about this, so I will go ahead. The burden of obesity, about 22 million Indians are obese, especially abdominally obese. This is old data, I say. In Jaipur study, there are 54% obesity was found in males. In another study in India, 23.7% ladies were found to be obese. In USA, 70% population is overweight or obese, and at least 33, one-third of them are obese. Most recent, that in 2015 data, after USA and China, India has highest number of obese people. So this is how it looks like. Causes of obesity in brief. This is, I think all the doctors are knowing it. Just I will revise it shortly. The main basic point is there is increased calorie intake and decreased physical activity. There is a disbalance. It can be genetic, it can be race. Secondary causes, you all know, so many hormonal diseases. That I will emphasize on drug-induced weight gain. Certain anti-diabetic, for example, sulfonylureas, thiazolidinones, steroids, psychotropic agents, lithium, antidepressants, antiepileptics, for example, valproate, gabapentin and carbamazepine. These may cause obesity. Pathophysiology of obesity. In abdominal obesity, intra-abdominal adipose tissue and subcutaneous adipose tissue may be there. In generalized obesity, mainly it is subcutaneous tissue. Abdominal obesity is more common in Indians and South Asians. Visceral fat tissues acts as an active organ, secretes large number of adipokines, leptin, adenopectin, TNF-alpha, plasminogen activator inhibitor, interleukin, your IL-6, angiotensin II, etc. Relationship between body weight and hypertension. There is correlation between body weight and blood pressure. 75% incidence of hypertension is related to obesity in certain studies. 70% of hypertensive men and 60% in women being directly attributed to excess adiposity. Even old Framingham study showed that 5% weight gain was associated with 20 to 30% increase in incidence of hypertension. Hypertension is a common component of metabolic syndrome. We all know in about 85% of patients. There is an ominous trend. Burden of obesity is shifting towards groups with lower socio-economic status and in poor developing countries like India. The prevalence of obesity in the developing countries has increased from 2.3% to 19.6%. That is, I think, 8-9-fold in 10-year period. So serious disease mortality is rapidly increasing in developing countries like India. Their BMI and hypertension, there is also, if the BMI is less than 35, only 15% incidence of hypertension. If the BMI is more than 30, incidence shoots up to 42.5%, almost threefold. Childhood obesity and hypertension, this should not be neglected because about 80% of obese children become obese adults also. A study in Germany and Switzerland has shown that hypertension was found in 35% obese children. Similar was in a study in USA. Indian had a small study. How obesity causes hypertension? This is important. Abdominal obesity means there is increased insulin resistance, hyperinsulinemia, and increased leptin levels. Another important point is activation of sympathetic nervous system, especially in kidney and skeletal muscles. Insulin also activates. Proof is that low energy diet in obese show decreased blood pressure and decreased sympathetic nervous system activity when insulin lowered by decreased energy diets. Leptin also activates sympathetic nervous system. Activation of renin, angiotensin, aldosterone system. Sympathetic nervous system increases renin release. increased aldosterone production and angiotensinogen from intra-abdominal adipocytes, increased sodium reabsorption due to increased aldosterone, increased insulin and increased angiotensin. Obstructive sleep apnea, there is also 42% increased chance of hypertension than persons with normal sleep apnea. Why there is need to treat hypertension? This is my first slide in most of the time in all other talks on hypertension. To prolong life and to prevent morbidity like CAD, stroke, CKD, LVS, LV dilatation, heart failure, retinopathy, etc. And not only millimeter reduction of blood pressure. And even 5 millimeter reduction of BP is rewarding. Risk of CAD decreased by 15% and risk of stroke decreased by 42%. Why some obese have normal BP? I will skip over it because time is short. Treatment of hypertension in obese. So basically it is weight reduction as it causes fall in blood pressure, and treatment may be non-drug methods like other treatment of hypertension and drugs. Management of obesity in hypertension patient. BP reduces by 1 millimeter with per kg body weight loss in obese people. So if you lose weight, you are going to decrease your blood pressure as well. Obese people with BMI more than 35 kg a square meter or greater, 10-year risk of development diabetes mellitus is 20-fold high. Even 5% reduction in initial weight is important in prevention of diabetes in these patients. Lifestyle modification. One study was important that even short term, 18 months weight reduction program showed 77% reduction in the incidence of hypertension. Advantages of reduction of weight. It is not only reduction of blood pressure, but there are other free gifts. Like you purchase something, you get a free gift for other thing. And these free gifts are diabetes associated mortality reduces 44%, cancer deaths decreased by 53%, there is decreased hyperlipidemia, there is decreased insulin resistance, there is decreased RBC aggregability, improved fibrinolytic activity, decreased incidence of sleep apnea, improvement in lung function, increased longevity, and increased survival by 3 to 4 months for each kg of weight loss, and there are many others. Management of hypertension in obesity, non-pharmacological methods I will not highlight because most of you know. Now drugs. Drugs are ACE inhibitors, ARBs, amlodipine, and central symptomatics, clonidine, moxonidine. Why ACE inhibitor and ARB is superior in treating obese people? Because drugs antagonizing RAS system have a special benefit on obese patients. Angiotensin is increased in obesity. ACE inhibitors ARB reduce markers of inflammation like IL-6 and HSCRP, and these are markers of inflammation, and decreased macrophage content of atherosclerotic plaque is also there. Macrophage produce tissue degrading enzymes like matrix metalloproteinases, and MMPs weaken fibrous cap of plaque and make it vulnerable. ACE inhibitors reduce matrix metalloproteinases. This results in stabilization of the plaque. ACE inhibitors ARB not associated with weight gain, better option if diabetes is present. ACE inhibitors and ARB prevent new onset diabetes in about 1/3 patients. Beta blockers and thiazides increase insulin resistance and increase incidence of new onset diabetes. These are some studies showing reduction in new onset diabetes by ACE inhibitors and ARB. In this also, ARB was superior to, as far as new onset diabetes was concerned, superior to placebo, chlorothalidone, beta blockers, diuretics, atenolol, and amlodipine. Meta-analysis of 2012, further evidence of RAS blockage. Meta-analysis of 13 major trials that included HOPE, Europa, PROFESS, RENAL, TRANSCEND, etc. Number of patients was more than 80,000, and there was decreased morbidity and mortality in normotensives also. So this is additional proof of superiority. There is also in core study that also compared diet. There was more BP reduction in weight management group. This was the final inference of this study. So to conclude, obesity is very common worldwide and is bound to increase. In US, about 70% population is overweight or obese. In India, 22 million people were estimated to be obese. This is old data. I don't know what is the current data. Obesity may be generalized or abdominal. Abdominal obesity is common in South Asian countries including India. There is a linear relationship between weight and hypertension. Visceral fat secretes adipokines, which along with increased sympathetic nervous system and RAS activity causes rise in blood pressure. Even a small reduction weight is rewarding in reducing blood pressure in overweight people. Similarly, a small reduction BP is also rewarding. Treatment of hypertension in obese individuals includes non-drug methods including weight reduction and drugs if needed for both obesity and hypertension. ACE inhibitors and angiotensin receptor blockers are better drugs as they antagonize RAS system and do not cause obesity, do not cause new onset diabetes. Beta blockers and thiazides can cause new onset diabetes in 1/3 patients, so best avoided. Except in certain situations where these have compelling indication, for example, a patient of CAD, you can use along with ACE inhibitors also. Unfortunately, prevalence of obesity is shifting from developed countries towards poor and developing countries. At country level, encouragement of physical activity and exercise are most important, as without spending money, both obesity and hypertension can be managed or prevented in the majority. Thank you very much.
Thank you, Dr. Harendra Kumar. That was a fairly exhaustive coverage on obese hypertensives. One important point about obese hypertensives is that while the first line of therapy remains the ACE or the ARB, it has been seen that as the second line of therapy, diuretics are better as compared to the CCBs like amlodipine. And they tend to lower the blood pressure better than would a combination of ACE or an ARB with a CCB. So that is, this is one of the specific points which is mentioned when we choose, antihypertensive therapy according to patient specifics. Like if a patient is obese, those patients would respond better to a combination of ACE or an ARB with diuretic as compared to a patient ACE or an ARB with a CCB. That is a very pertinent and important point.
There is no class between ACE inhibitor and diuretics. Both can be combined.
No,
it's a synergistic combination.
ACE inhibitors with diuretics, yes, they are pretty safe.
Even ARV, they are all can be combined. They can be always, combination is always better.
Okay.
This is another thing.
That was a great presentation, very comprehensive, Dr. Kumar. Can I add one more point to that?
Yes.
Apart from medications, we have been using CPAP machines nowadays in obese patients who are resistant to all the medications, or as the second or third line. I would have a sleep study done on these patients, and inevitably most of them have sleep apnea, and after using the CPAP machine, they come down to just one medicine or probably get off it too.
Okay, thank you.
Obese patients which will have obstructive apnea, then only they will allow us for CPAP. Nobody will allow us to use CPAP.
That's right, but it is underdiagnosed in most of these patients.
Thank you. Thank you very much, Dr. Kumar.